Hello, everyone, and welcome to our special session today. My name is Anafi Matak. I'm from ASLM, where I play a dual role as a project lead for our United funded project on innovative diagnostics, as well as our laboratory systems community of practice, where I serve as the project manager. Today's session is a special one in which we are talking about a key element that has always been a thorny issue in most of our systems, the issue of connected diagnostics. We know we need systems approaches to care. Patients need results anyway. Healthcare workers also need the results anyway. We want simpler interpretations and of our results and algorithms. Programs need better data. Local and global partners actually need faster data for easier implementation. It could be for M&E, it could be for targeted interventions, it could be for outbreaks, as well as for other scientific bases. We are living in a world which we could call a smart era: smartphones, smart patients, maybe smart labs, smart clinics, smart tests for us to move forward. So today we decided to have this special session in which we look at important elements with regards to how we are collecting all this data to inform all these things that we need to do. And to do that, we have two presentations that will come first for the first about 30 minutes, followed by a question and answer. We are glad to have today our first presenter from Uganda. Her name is Proscovia Nambuya Mbabasi, who is the head of information communication technology at the Uganda National Health Laboratory Service, Ministry of Health, Uganda. She will give us the first presentation first, and then this will be followed by another presentation from Mozambique by Chishamiso Mudenyanga, who is the program manager at the Clinton Health Access Initiative in Mozambique. I would like to call upon Proscovia to take us through the first presentation. Meanwhile, just a reminder of the logistics during the session. As the session continues, please enter your questions or comments into the chat box, and we shall take the questions from the chat box after the presentations are done. Stay put and enjoy the presentation. Over to you, Proscovia.
Thank you so much, Anafi, and good afternoon, everybody. I will go straight since already the introduction has been made, but I work with the Ministry of Health, that is the Uganda National Health Laboratory Services, and I head IT services. So we are talking about data connectivity and management and connectivity. Now my screen starts to refuse to move. Sorry. Okay. Well, the screen is failing to move.
Try to share again, let's see. Okay, seems it's moving now.
I just want us to dive in because I've lost a few minutes. Sorry.
All right.
So data management, we are looking at the process of collecting, storing, protecting, and analyzing. Then you can use the data, and it should be secure, it should be efficient, and it should be cost effective. And when we get into data, if I go electronic, governance is the biggest aspect of it. Who is responsible for the data? Who is responsible for storing it? Who is responsible for sharing it? We look at the architecture in terms of where it flows from the point of collection up to where it is shared and utilized. But if we go into data systems in terms of electronic, we look at the different database systems where you arrange your data, whether from the lowest facility or a reference laboratory, if we can speak in that aspect. And then we go to the master data and metadata. Metadata, we look at the different pieces that are stored in the different places, and the master data is the whole piece all together. Many countries are using DHIS2, and there are those that have moved from the point of picking data from different systems and sharing it in DHIS2. So DHIS2 in this case would be our master data. But quality control is very key. You've heard of DQAs, where we have to clean the data and make sure it speaks to the actual picture that is on the ground. And then we also look at integration of different pieces of data from different sources. And then we can talk about warehousing, where we are talking about big data. And from here, we should be able to transform this data to make meaning decisions to whoever needs to look at it and make decisions. So that is the whole aspect of data management. I would like us to appreciate what we are getting into. And as you go on, when we talk about my slides are refusing again. Why should we care about data? Why should we care about managing data? If you see the guys on the screen where there is no data and technology, it's like walking to a destination blindfolded. Because you need to be able to improve care for patients. You need to be able to have informed data-driven decisions. You need to be able to do research. Not every time you need to do a research, you go and collect data, but it also simplifies reporting, monitoring, and evaluation of the different programs where data is being collected. And if we look at paper-based kind of data management, like you look at this man, it can be hectic, it can be troublesome if you need to go back and be able to analyze and make decisions. So transforming this into application so that it's more of a service delivery, but of course you have to take care of the change management of those who are used to paper-based, and then you need to go to look at maintenance, look at the deployment, look at the security, look at the business continuity to make sure that the data is available for you to continue giving services to those that need the service. In this case, we are talking about healthcare. But why specifically laboratory information systems or laboratory data? We are looking at the different pieces, and we are looking at automating laboratory pieces, laboratory processes, but also ensuring timely results delivery, and also being able to trace a sample or machine reagents and be able to understand the personnel who are doing this service or testing and be able to analyze the results. You are able to also to collect and archive and use the data to make the decisions like we are now talking about the COVID-19 pandemic. And yes, we look at too many records, too many entries. When we do manual, of course, we do a lot of transcription errors, but you also talk about long turnaround time and reporting of patient results, which is also delaying patient care. And if there are referral samples in Uganda, for example, you talk about the hub system. If the samples get lost along the transportation network, it's hard to be able to trace them. And then you have to do manual accountabilities and it's quite hectic. And of course, the reports can also fall through the archives as you do the recording. And also, if we have, in Uganda, for example, we have several systems, but the data is so scarce, it's not shared with the people that need to use it. But yet we might need to make very urgent decisions, like we needed data for us to see whether we should lock down the country or we should open up certain sectors of the country. So in Uganda specifically, we have several systems. I'll talk about the conventional systems and about the point of care kind of systems. We have the viral load systems, which is a reference conventional. We have the early infant diagnosis of HIV, which is both conventional, and we are going into point of care. We have the Africa Laboratory Information System. We have results dispatch, where people are able to log in and pick their results electronically, even if the testing is done centrally. The example I can give right now with the COVID-19 testing, the different districts are able to log into one point and all are able to receive their results in a timely manner. We also are tracking samples. We are also taking care of the inventory. We are also talking about facility ordering for the commodities that need to be used, especially when it comes to the conventional systems. And of course, with this, you will need to have the automation is very, very important at the testing laboratories. And if you need to do this to the peripheral facilities that are sending in the samples, you might need to talk about a few aspects of automation. And yes, you can see that here in Uganda, we are talking about both conventional and then also the point of care. We have developed dashboards for us to be able to transmit the data that is transformed for analysis, but also give room for conventional samples that are transferred to the central level to be accessed in terms of results, and then be able to give delivery of service to the people in care. But we are also, as we go into the point of care, like you can see, we can still be able to see what the facilities are doing in terms of the number of tests, in terms of the machines that are being used, and in terms of the positives and negatives. That is for HIE here in Uganda. We are using the PIMAs, we are using the GeneXpert machines, and at one time we were actually also using the other technology. But this, you need internet to allow people to be able to log in and access the data. But all this you are trying to do is to be able to have time decision making.
I'll be here. Why?
All you need is, like you see,
Have you brought that?
for example, we have different facilities. Thank you. Like you have Jinja Regional Referral Hospital, Matany Hospital, all these people are able to access their data that is centrally processed through the electronic results dispatch system. All that the facility needs is a computer, printing, paper, and then internet. So you just give them credentials, they log in, and they are able to access their data in real time. As long as the reference lab has finished the testing, immediately uploaded the results, the facility is able to access. And then at the center, you're also able to monitor whether these people have been able to access their results and be able to print them or not. We are moving to the next level where we are able to do mobile technology, where it is possible for you to see whether the actual patient has actually been able to utilize the result or not. And I just wanted us to look at the different connectivity solutions that we are using in Uganda. There are those mobile USB modems, and then We also have VSAT technologies in some facilities, but we are also having some optic fiber communication in some facilities. But there's also a plan for the country through the National IT Authority in Uganda under the Ministry of ICT to ensure that there is last mile connectivity to at least health center 4s in the country. But as we speak right now, most of the regional referral hospitals, about 15 of them, have connectivity at their doorstep. So it's a matter of getting this into the whole facility. So that is the plan for connectivity and it is ongoing so that facilities are able to share their data in real time. Right now in Uganda, from the laboratory perspective, we have projects that are ongoing. We have laboratory information systems installed at the different facilities in the country where you're able to do your laboratory processes and report data. So we are building a data warehouse where we are able to see what is happening in terms of the number of tests, what type of tests, in terms of reagents, which ones are there, which ones are not there. We hope that by the end of 2020, we have a few months, we should be able to see this data in real time. We are working on this. And then we are also working on health information exchange for our several electronic medical records and the laboratory information system at the different facilities. Right now, we are exchanging data from the electronic medical records from some facilities, and this data is exchanged with the viral load laboratory information system at the national level. So we are able to receive the data requests from the EMR, 2 of the different EMRs, and then we are able to process and send the results back to that EMR. This is a project that is ongoing. We are planning on scaling up to all facilities that have EMRs in the country. Then I've also shared about our internet connectivity plan, and we also believe this will give us very good mileage. Some of the challenges, yes, we have challenges. People changing from paper-based to electronic, it's a change management kind of process. Then adoption and acceptability, part of the change. Sometimes people are used to the way they've been doing things, and then you're introducing something new. But the experience is once people get used to the electronic bit, they do not want to go back to paper. That's the good news I can report. I have also talked about internet connectivity. There are a few places that have no connectivity, and there is no laid up infrastructure to make sure there is internet. But like I said, we are planning to get there. So of course, training is part of it. And sometimes the HR gaps, you train someone today and after a few days, they have moved to a different place and new people have come in, and then you have to go through the training over and over. And of course, it is a process. Most of our software in Uganda is developed locally, and as changes happen in terms of processes, you have to keep changing and updating. And of course, not every facility in terms of planning has the hardware that needs to be, but we seem to be almost getting there. Some of the suggestions that I would like to push forward, it's so important for especially program managers, clinicians, technical people in the laboratory to embrace and plan and use technology. It is the best way for us. We are going to be able to manage data efficiently. We also need to be able to standardize the data. If I am speaking about a request form, the clinicians should be familiar with it. It should talk about the same data across the board. And then we should be also able to utilize the data that we collect. We also need to incorporate technology when it comes to budgeting and planning to ensure that all aspects that need data collection are taken care of. We also need to go in the way of seamless information exchange, where we are exchanging data and utilizing it without necessarily seeing what is happening in the background. It doesn't matter which type of programming language you have used or which type of platform you are using, but we should be able to share data. given. For example, in Uganda, there are several information systems that are in play, but we want to be able to have them speak to one another. Of course, it's also important for us to ensure that data that is protected because it is sensitive. We are talking about a patient specifically of whatever kind of form. This data should be well protected. It's very, very important. So we need standards and guidelines to make sure that all this is well taken care of. In conclusion, to design and implement any data management system, you require a team of experts. Experts doesn't mean the software developers or the information scientists like me. It needs people who understand the sector, the technical people who understand the sector, working together with the software designers, the software developers, and then the system analysts. And then we have to include the logistics because we need to plan for procurement, for the implementation, for the training, and all this includes financing. And we need to have a strategic plan and a financial plan for us to come up with a detailed project of who, what, and where, and when, for us to be able to improve efficiency and effectiveness of the process of installing and designing and implementing data management systems. We also need to be able to appreciate the needs and define them clearly according to the users. And we are talking about the technical people in the environment of public health. And then we'll be able to choose a solution that actually meets the needs of the technical people, and it should be within the budget. So we should be able to appreciate the business processes and define the system according to the business processes. Then we also need to be able to adopt and train the different users that are going to use these data management systems. But we also need to continuously support and maintain and update the systems according to different software requirements that come up. So it is very, very important that we plan and incorporate data management so that we are able to come up with data-driven decision making. So we do not have to repeat the same data collection over and over, but we can look at the historical data and be able to determine the future and also appreciate where we are in the current. Thank you very much.
Sophia, that was a wonderful presentation indeed. Many of our colleagues are acknowledging that in the chat as well. So thank you very much. As we have mentioned earlier on, we will go into the second presentation. So please hold on to your questions and comments, and we will be taking them, keep them coming actually into the chat box, and we will take them after the second presentation, which I'm going to call upon Chishamiso Mudenyanga from Mozambique, who's the program manager at CHAI. Chishamiso, over to you. Shami, you are on mute if you are speaking.
Okay, sorry, I didn't realize that. Good afternoon, or hi everybody, and thanks to Proscovia for that superb presentation. I will just try to go through this as quickly as I can because of the time, just to share our experience from Mozambique side regarding connectivity. You know, this is in the context of point of care, which is an area that as CHAI we are supporting in Mozambique. And the background of the benefits of connectivity really for us, which probably apply to everyone else, is mainly based on the need to improve data visibility. We need to know what's happening at the health facilities. We know what is the performance of the operators at the health facilities. It also helps us to improve in our CQI, our continuous quality improvement, as we can be able to monitor the operators and in general, the use of the devices at the health facilities. And it also helps us to manage stock, you know, and as a result, we can be able to avoid or reduce waste due to expirations, because all this we are able to monitor remotely using connectivity, as well as to reduce our cost of poor quality in terms of controlling or intervening in a timely manner to reduce errors that are avoidable, as well as to improve the link between diagnosis and treatment of patients. So I'm just going to walk you through this Mozambique approach on connectivity for lab across our point of care systems. Just as a background, Mozambique has got probably the most number of point of care devices in use at the moment, with over 198 devices deployed for point of care CD4 and 135 to date for point of care early infant diagnosis. So with our point of care platform, what happens is we have remote transmission of data from the operators right at the health facility into our cloud-based database, which is provided by the manufacturer of these devices. In this case, is Abbott. And in this platform, we can access all the technical information that we require concerning these platforms, including who are the operators, which sites are sending data, which sites are not sending data, you know, which operators have not been operating devices for a specific period of time, and be able to identify even where there is needs for human resources. So this helps us to monitor or control this while we are from our offices. So regarding data utility, who are those who have got access to this data? We have managed to delegate access to different levels, starting with the central level, which is the Ministry of Health itself, and other partners who are involved in the implementation, who are mainly involved or interested in clinical management or clinical follow-up of data, as well as the provincial level, where we have the different provincial MOH personnel and provincial partners as well, accessing data specific to a given province where they are, as well as we have the people that I would call the on the ground managers, whom we call point focal for each province, that are responsible for supporting the program on the ground in each province. And these are the same people who are responsible for reporting to the provincial level as well as to the central level. So this wide distribution of access helps keep everyone or every interested party involved in the management of the program, and therefore also permit ease of interventory measures to control the program. So these are the main objectives of our monitoring using connectivity. Like I mentioned earlier on, we have to we monitor error rates so as to reduce our cost of poor quality. We also monitor operators' performance. This enables us to identify operators with high error rates who need to be retrained, or operators that have been trained but are not operating the devices, because we need to ensure that our training is cost effective, as well as enable us to identify any training gaps, and therefore we can reschedule trainings or technical assistance that is required. It also helps us with monitoring of stock, like I mentioned earlier on, monitor the performance of devices, ensure that there is a timely swap out of devices that could be giving problems so as to avoid high error rates. It also helps us with identifying, where most of our patients are coming from, even their ages, what is happening with the reference system. As most of you could be aware, when we're talking about EID, for example, there's been push for increase of testing for EID through accessing alternative entry points. And so with coding patients, we can be able to identify which areas are we getting more patients, or which areas are we not doing more in case of patient identification. We also use the same to promote adherence to national testing algorithms, whereby we can be able to identify who is adhering and who is not, and therefore enable us to strengthen adherence to these guidelines. And also the same serves to monitor EQA participation. You know, when we don't have very good infrastructural systems for sending back and forth the results, and therefore using connectivity, it is easy for us to monitor EQA participation across all the sites in the country. As well as, clinically, like I mentioned, whatever diagnosis platform we have, it serves as an entrance to treatment or to monitoring or care of patients. And using connectivity, we are able to identify patients that have been diagnosed as positive and give them the necessary follow-up to ensure that they are introduced timely into treatment and necessary follow-up. And therefore, this is what we basically are doing with connectivity in the country, and we are able to identify where errors or intervention could be required. And just to give you a snapshot of some of the results that we have seen to date because of use of connectivity in Mozambique, I think this graph shows you what has been happening with the error rates from the inception of point of care EID, and as time went on, you realize that when we started off, our error rates were approximately 12%. And in Mozambique, we have set a target of error rate of not more than 5%. And therefore, you'll see that across over time, due to monitoring and giving the necessary technical assistance and retraining and orientation to operators, we have been able to reduce the error rates over time. And also regarding adherence to testing algorithms where patients are supposed to be confirmed if they are positive, you realize also that in the beginning, because in Mozambique, we use nurses and not lab personnel for point of care testing, there was an issue regarding adhering to treatment, to testing algorithm. And over time, you see how this improved. We're almost nearing 100%. But of course, like Proscovia also mentioned, we have staff rotations, and this always will be an issue. And hence you see to date, we haven't managed to hit our 100% target. So point of care is very ideal, you know, in supporting the continuum of care and treatment, because, for example, when we newly identify patients using point of care, we are able to implement or instill quality assurance or quality control. And at the same time, we're able to monitor our supply chain, like I mentioned earlier on, monitoring of stock. And therefore, we can also support our patient flow and clinical integration, whereby we are able to identify patients that need treatment and ensure that they are linked to the treatment arm. And with time, it's easier for us to monitor treatment adherence because we already identified these patients and we know that they are now in the system for treatment. Just to also mention that we do not run point of care separately, but we run point of care in conjunction with the conventional system, where we have two data streams that we are running in the country, where the point of care data is fed into the national database, which includes the conventional results for the lab. And this conventional or this national database is then used as a national database for monitoring all our EID or diagnostic abilities or activities in the country. So I will not go into much detail into the national database, but it is very it's very detailed because it's not only technical, but also it involves demographic data, which is useful for our PMTCT program, where we are able to tell what is our age range that we are mostly testing and what is the linkage to treatment, what ART regimen the parents would be on. And so, like any other system, we always have some challenges or some hurdles that we need to iron out. before we can really say that the system is smooth as desired. And in our case, like Proscovia also mentioned, we have mobile network limitations where some sites, they have challenged the network, and hence data transmission is not always as desired. We also have operators work culture because connectivity honestly depends on the operators manually activating the sending of data to the database. And sometimes due to work pressure, this is forgotten, it's not done, and follow-up needs to be done. And then also staff rotations where staff completely are new, they don't know the procedures that are required to be followed. And this also needs to be followed up. And lastly, you know, we have the different levels that I shared earlier on that have got access to connectivity, but you realize that in most cases, or in some cases, data utility is not as desired. And at times, some interventions can be delayed just because access by management was not done on time. Regarding sustainability, in case somebody might be wondering, so how do you sustain this program in Mozambique? I think for us, the good thing is the manufacturer is 100% responsible for this cost, whereby the transmission through the mobile networks, it is covered by them. I think our only responsibility is to ensure that we maintain or replace the modems that are required for data transmission. And also we have got partners engagement in the country who are supporting the ministry in supporting the program. And this also helps reduce the cost burden on the ministry. And the local representative from Abbott in country is actively involved on the ground. And that enables us to get a rapid response that we need to ensure the smooth running of the program. So in a nutshell, that's all I can share from the Mozambique side. Thank you for your attention. Back to you, Anafi.
Thank you very much, Chishamiso, for that wonderful presentation. Very insightful indeed. So we get to that stage where we are now going to be going into our question and answer segment. And I would like to quickly take the first question that came from, let me take this one from Huluka. And I think this one was addressed to Proscovia, and he or she says, how could this be customized to MCM One Health approach? Proscovia.
You want me to take it right away? I had taken a note of a few. I can respond to some of them at the same time. That one was one of them. In Uganda, we started, for example, our conventional testing through the National Hub Transportation kind of system. And it was only HIV early infant diagnosis. But as we speak right now, the same platform, the same system of sample transportation is being utilized for all kinds of samples, including the animal samples as we speak right now. So even in the systems perspective, we are looking at systems that can be able to address all kinds of samples that we can talk about, all kinds of testing that we can talk about. So in that issue, we are talking about interoperability, and interoperability, I saw another comment saying that comment on interoperability, so I can dive into there after my first question. We are looking at one, interoperating people that are working on the different aspects, that is the clinicians, the laboratory people, the ones in the animal health. And then we are looking at interoperating systems, and then we are looking at interoperating programs. One program that fetches into the other. So in Uganda, from the systems perspective or from the data management perspective, it doesn't matter what kind of platform that you are using to generate data on the other side. We are using the approach of open health information exchange system, where It doesn't matter what kind of environment you are coming from in terms of designing your data management, we can still be able to pull data to one point. And for us to be able to share, we leave your data structure the way it is, and then we are able to share the data that is necessary from one system to another. And actually, enough if I can go on, the next one was challenges of fragmented systems in which incompatibility issues, how are you going around it? It is the same story. We are using interoperability not to disrupt the different systems that are existent, but for us to be able to pick information or data from those different pieces into one point where we are able to speak. So we are expecting that one system can be able to speak to one another. We started this project with viral load information system with different EMRs. Currently, as we speak, this concept has been proved. We are able to pick data from the different pieces of information systems. And we have also gone into, currently we are working on COVID-19. And in Uganda, if you're in East Africa and you're coming to Uganda, or you're going to Kenya, or you're going to Tanzania, you're supposed to have a valid COVID-19 certificate that is not later than 14 days. So right now we're able to interoperate the system of the East African community with our Ugandan limbs. So we are able to pick data for us to be able to see that this person actually has a COVID-19 certificate that is valid. So in Uganda, we have made progress around this area of incompatibility, of interoperability, and we do not mind what kind of information system and what technologies you have used. We are able to still exchange data. And enough if I can go on, the next one was, how do you ensure that information and information systems are well protected from unauthorized access, disclosure, destruction, and modification? In our design, one is security is very paramount. Access is only to those that are authorized, and access levels are also very, very limited. And like we said, with the viral load, which is conventional, and the EID that is conventional, different facilities are able to log in and only access their own data. If you are in a Jinja district, you can only see data that belongs to Jinja. If you're in Mbarara, you can only see data that belongs to Mbarara. So the aspect of security is very important, and you are not authorized to edit or change anything. So we take care of this, and we haven't had issues where there are changes in the data. We only had an issue where someone can pick a different name and print a certificate and put on a result that is not theirs, but we also added a security feature where you're able to first check the QR code and confirm that the names that are there actually match with the results that were generated from the system. I could stop there for now. Thank you.
Thank you very much, Proscovia, for taking those questions. Really important points indeed. Interoperability is quite critical, like you have mentioned. The beauty of the sharing information like this is we all usually have the same problems. What maybe differs is the scale of the problem. So I think we are actually getting to learn one or two things, and I picked interoperability being a key element in there. So let me take a few questions also. I think some were directed to Chishamiso. They're coming from David Ochieng. He speaks around 5% error rate is being quite significant in laboratory testing and client management. And he says, any strategy to reduce this gap? And I think it also goes around along the same line where Clifford Mulu also speaks around how connectivity monitors testing algorithm, and how you also link between HIV rapid testing and POC via connectivity. Maybe Chishamiso, you can take those two, then we can move on.
Okay, so the first question is regarding rapid tests. We do not have connectivity covering rapid tests in Mozambique because right now, I think those of you may be aware, Apple just recently introduced rapid test reporting through connectivity to a central database. We haven't adopted that as yet. So we are simply using this for point of care EID and also for point of care viral load as well as CD4. Sorry, I'd forgotten that. Regarding the error rate of 5%, this is our national average error rate that we look at. And we put this at 5% because we're looking at how much will be the cost implication of an error rate of 5%, especially if you're looking at donor funds that are mostly used in some of these programs. And through technical assistance that we give and also daily monitoring of data on data point by the point focal at each province and at the provincial levels and also at central level, we can be able to bring intervention measures in real time and resolve any likely cause of errors on time. So that's how we are doing that. I can't remember the third question. What was it about?
I think you have answered those questions, but whilst you are still there, and I think this also applies to Proscovia, somebody asked, do you use unique IDs? And I'm linking this question to the one from Brian Richards, where he's saying, how do you match a lab result data automatically sent by the Abbott POC devices to a patient or a case? Then he goes on to ask around the issues of interpretation, but an element of linking unique IDs to patients, maybe possibly for lifetime management. Maybe a comment around.
Okay. You go.
Okay.
You go first. Okay.
Okay. So in our case, each patient in Mozambique, they are given a patient ID that is given at a health facility. So this is a number that they use as long as they are consulting at that particular health facility. It identifies them. And we use this same number as a sample ID when this patient is being tested on an EID device. And the same patient information that we are using to capture on the point of care devices, we also complete a laboratory requisition form that was being used before point of care was introduced and is still being used to date, is slightly adapted, for point of care as well. So the patient's information is captured, all the demographics and the patient ID, and this same form will be transported to the reference lab where data capture is done into the national EID database. And there the matching of the patient is done using that patient ID, and the rest of the patient's details, including the full name, are kept in that system, and that's how we ensure that they are linked.
Wonderful. Thanks, Shamiso. Proscovia, how do you deal with the issues of unique IDs and being able to follow?
That is Uganda's one biggest challenge. We do not have nationally recognized unique identifiers for patient care. But as we speak right now, we are moving into using the national identification number. But previously or currently, before that is scaled up, we have just introduced what we call barcodes. These barcodes, still, they are not one time. They are related to the visit to the facility. Or for the viral load, they have their unique, for example, AT numbers, but still it's not unique across the board. So they are only unique in that particular facility where they are, for example, taking care. but we are moving to a level of introducing national identification numbers for us to address the issue of unique identifiers. But currently there is no that policy of unique identifier. If a patient moves from one facility to another, they will have a different number in that facility. If they go to a private facility, they will also get a unique identifier in that particular facility. Thank you. Probably, Anafi, if I can go on, there was another question of is there any offline software which can be implemented where there is permanently no internet? Like I said earlier, if, for example, you went to a reference laboratory, you have a local kind of information system that can work without the internet, but it will help you do the processes in that facility. Or if you went to a local facility at Health Center 4, where, for example, we are doing POC, the facility will be able to do their local processes and have their data in the system locally without internet. Challenge of internet is only when we are talking about sharing of data. So when we need to share the data with a remote facility, that's where internet comes in. But as we speak right now, most of the database systems or the softwares we are using are local. We need internet when it comes to the aspect of sharing. Or for example, you need a facility to get a remote access to their results, that is conventional, or you want to get data from a remote facility that is doing POC at the national level, they will need internet to push. Otherwise, these information systems, these database management systems are actually locally not using internet within the facility. Thank you.
Thank you, Proskovia. And I think just want to take another question, and this is really also from my personal experience, and I'm glad, Bright, glad to be here with you, Bright. You mentioned this one, the issue of data ownership. I know it has been a sticky point. How do you handle issues of country data ownership? If the service provider seems to be in full control, sometimes these are hosted outside. How do you convince ministries of health or those who are actually in charge of information? Sometimes these are not Minister of Health, but probably Minister of Communication.
Can I go first?
Go, you can go first.
Okay, so in Uganda, it's now like a rule, Uganda's data should stay in Uganda. So in the POC, like there are those cloud-based systems where data is pushed specifically for monitoring the performance of the analyzers. So in Uganda, what we did is the details of the patient data stay in Uganda, and then the details of the machine in terms of performance and error rates go to the manufacturer. So we have a platform where we pick data directly from the machine. There was also another question of picking data from the analyzer to the laboratory information system. And yes, here we have been successful with some of the analyzers where you directly pick data from the analyzer into the laboratory information system, and that is detailed patient data. So the data that goes to the manufacturer or the vendor is the data that is related to the performance of the analyzer. So in Uganda, it's now common knowledge that if you're going to have any kind of placement, we have to also talk about the data management and data storage. And we are glad to report, like in Uganda, we have an excellent data center, or we have the capacity to be able to store all kinds of data. So it is an agreement that the country's data should stay in the country, and then the data that goes the other side is data that is related to the performance of the analyzer. Thank you.
Thank you, thank you. Chishamis, how did you deal with the issues of data control?
So I think our case probably is similar to the Ugandan one. Data is actually owned by the Ministry of Health here. It's not shared externally. So the national database, which is the ultimate source of all the information that I was sharing about, be it point of care or conventional, it's owned locally. You know, it's the server is locally. But the technical database, which I was referring to, which is on the cloud and just receives information or results directly from the devices. See, that's on cloud, but it's only technical information with not interpretable patients' data outside of Mozambique. And for that, the Ministry of Health is comfortable with the approach as it is for now. Thank you.
Okay, thank you very much. I know Makune from Zim is also quite some experience with regards to point of care, and I think he wanted to talk around the issues of. Let me ask him to unmute. Makune, can you hear me? To share issues around connectivity.
Hi, Anafi, I think you have me confused with another Makune. This is Makune from Tanzania, and I had raised my hand earlier. Thank you to the team for the presentation. It was very enlightening. And I wanted to say a few things. First of all, I think with regards to data connectivity, I don't have something to say at the moment, but I wanted to say something regarding data use management. And I don't know the way it works in Mozambique or Uganda, but here, some of the data connectivity requires a computer connection. And when you have a computer in the lab, sometimes there's misuse of the internet connection. So you'll find a couple of the lab personnel using the internet for things like YouTube or things of the like. How do you regulate things like these in your countries? That's the first one. And then I also had...
let's take that one since we are only remaining with a few minutes. Yeah. But I think
the other one was a comment, not a question. Regarding the challenges that Uganda was facing with personnel moving from one place to another. I think one of the ways that you can regulate this is to certify the personnel so that even if they move from one facility to another, you know that you don't need to retrain them. They're already trained. And if ever this other facility will need such a training, they already have somebody who's trained. But also to emphasize that these personnel conduct on-site trainings or knowledge transfers to the people that will be in the facility or the facility that they are leaving, so that you don't have to really retrain, but more so conduct the refreshers.
Thank you, Makune. I think that is very insightful indeed. Certifying the personnel so that they can even go to another facility and continue to show their skills as well. This has been really an exciting presentation, and this morning I bumped across this slide, courtesy of Prof. Wendy from WITS, and it just really caught my attention. All what we've been discussing, you know, really in the lab is really application beyond just the result reporting. I think both presentations brought how operational dashboards can actually be used to monitor our systems. I think somebody sent me a question on how does this really relate to algorithms? How does it relate to issues of surveillance? I mean, we will be able to use this information that we gather in real time to inform where the gaps are in services, really. We have been talking about network optimization, and all this is coming through. How do we place instruments within this tiered network. So if we have efficient systems, connected diagnostics of collecting this information, it means all these processes that we are going to be doing will actually be relying on more accurate data as well. We talked about unique IDs, and they will be very crucial when we want to really follow cohorts in our systems and really ultimately measure program success. We have always been talking about integrated diagnostics. And this actually should be applying in all services, all tiers of the laboratory network. So I felt like this really summarizes what we have been discussing today. And it's been really a wonderful presentation from both the colleagues indeed. We have got to a time where we need to be saying goodbye. But really, I think we want to thank all of you for coming through to this presentation. And we shall be sharing the slides and the responses to the questions as usual. So as we are about to go, I'm going to be sharing a slide which has the code for downloading the certificates for those that who want to be able to go to our site and download. Please give it a day or two for them to be able to upload the video as well as the relevant items for you to be able to download the certificate. And till we meet again, I think I'd like to say thank you and goodbye. I will leave this for about a minute or two for you to be able to check the code for the certificate.